So the title of my talk comes from Hippocrates. He wrote in around 400 BC in Of the Epidemics. He said that the treatment of disease, it consists of three things: the disease, the patient, and the physician. Specifically, the physician is the servant of the art, and the patient must combat the disease with the physician. So the significance of this in this talk is that during COVID-19, public health policies, I will argue, completely sidelined all three of those things. So in terms of the disease, the accurate information on the actual disease seemed to be irrelevant. What was more important was what the modeled disease and the disease that the media was reporting on. Now, in terms of the patient and the physician, the individual circumstances of the patients and the clinical expertise of the physicians, they were downranked, completely subservient to the nationwide one-size-fits-all policies of the health authorities. And those were unusually influenced by the commercial interests of some specific pharmaceutical companies. So the structure of this talk, I've got to do it in 4 parts. Okay, so you can see this, okay. But before I get on to the first part, I'd like to just make a disclaimer. So a lot of, particularly for those of you who are watching online, at different platforms will say that, you know, if you disagree with the World Health Organization's current position on something, that this needs to be flagged. So some of the content that we'll be discussing does disagree with the current position. So we need to say that in terms of COVID-19 vaccines, according to the WHO, as of July 2024, they provide strong protection against severe illness and death. Although a person can still get COVID-19 after vaccination, they are more likely to have mild or no symptoms. We will also mention ivermectin. According to the WHO, the current evidence on the use of ivermectin to treat COVID-19 patients is inconclusive, and until more data is available, they recommend that the drug only be used within clinical trials. Okay. One of the things that a lot of us discovered over the last 4 years, we were supposed to be following the science, but the science that we were supposed to be following seemed to change from week to week. And this is the same with the WHO. For instance, up until August 2022, the Pfizer COVID-19 vaccine had been thoroughly assessed at the quality, safety and efficacy of the vaccine, and was recommended its use for persons above the age of 16. After 18th of August, though, there was a very rare serious adverse event. Before August 2022, it was 95% effective against symptomatic COVID. If you took it, you were 95% chance you wouldn't get sick from COVID. If you took it before 18th of August 2022, then they said, oh, well, you can still get COVID, but it might reduce the severity of your symptoms, okay? But up until January 21, it wouldn't have even been a vaccine. The definition of a vaccine was changed, thanks to Merriam-Webster, just in time for the vaccine rollout. So that was very nice of Merriam-Webster. And so I guess perhaps 2024 is the sequel to 1984. So as we are told, the new science, as the science changes from week to week, this is probably the advice I give you. When you're getting the new information, remember to forget what you remembered from last week beforehand. So that's 2024 life. So I got to give a shout out to some of the colleagues that I've been working with on this, and there's many, but doctors Jerry Quinn, Colleen O'Hashu and Paul Hines. You heard earlier from my father, Michael, and also from Willie Soon. Many co-authors who I've been working with and collaborating with. It's been a very interesting experience. These are the papers that we've published so far. So one of the things that we've discovered is if your research disagrees with a current WHO narrative, getting it published, it can take years. It can take years. So we have other papers, and some of them involving a few DDP members as well. Hopefully, we will be able to talk about them soon. But for the moment, we have these papers have been published. And so let's get on to the first part. So the first part is about the models that people used. Now, in 1927, these two Scottish epidemiologists, Kermack and McKendrick, they came up with, bear in mind, this was before computers. So it was a remarkably very clever set, model that they developed. It was a set of differential equations to try and understand how an epidemic or a disease outbreak changes over the time using differential equations. And the thing is, almost all of the computer models that were used to advise governments on COVID were using this framework. So it's worth digging into it a little bit. So their basic premise is they assume that at the beginning of an epidemic, 100% of the population is susceptible. Their original one didn't include the E. Some groups will add that in. But once somebody got exposed to an infected person, then they became infectious and then they recovered. So it's SIR model, S-I-R or SEIR. And the motivation you'll see for a population-wide vaccine program was if you had a safe and effective vaccine that could provide you with sterilizing immunity or even immunity equivalent to recovery, you might be able to just bypass that. So remember that. That's according to the model. So the key bit of the model is they have this thing called an R0 value, reproduction number. And what that says is, on average, when somebody gets infected, how many other people will they infect before they recover? So it varies from disease to disease. They still don't know what value is appropriate for COVID, but if you would say 3, then you'd say each person, they get sick, then they infect 3 others, then they recover. Those 3 others each infect 3 others. So you can imagine it rapidly goes through the entire community. If it's 2, then it also does it, but at a slower rate. If it's 1, then by the time each person is infected somebody else, they're recovering. So the total number of people who are sick at any given time should remain constant if R0 is 1. Now the significance of the SIR model was their differential equation said that over time people have recovered. That means there's less susceptible people. So they said that the effective R0 should decrease over time. So specifically, as you get more and more, at some point you will reach a value where the effective R is 1, and as we saw, if it's 1, that means you're not going to get an increase in cases. So that's called the herd immunity threshold. Now, the epidemic will still continue a little bit further, but the cases will be gradually declining. So that is the model, the SIR model, and these are the implications. So this is really important to understand because governments around the world, the modelers thought that we're using this simple model. They believed this is what would happen in the absence of major and unprecedented interventions. And they told governments, you need to do this or this is what will happen. And the governments panicked and they said, okay, we've got to do it. So what were they afraid of? They were saying there would only be one wave. This is the curve that people wanted to flatten. And they said it would only last a few months. It would affect, within a few months, almost everybody in the country would have been sick. And at the peak, you'd have 10 to 25% of the population sick at the same time. Just imagine the consequence of that. Hospitals would be overrun and the hospital staff would also be sick. So hopefully you can see why they were panicked about that. But just to give you an idea of the crude nature of this model, the it only outputs, because it was developed in 1927, it only outputs number of days since the start of pandemic. So it gives you the same results if you started in January or July. So there's zero seasonality in this model, the default one that most of the groups were using. So now let's understand the history according to the official narrative. So early 2020, the governments saw these results, and almost all governments said, we've got to introduce unprecedented levels of what are called non-pharmaceutical interventions, or NPIs for short. I'm going to be saying NPIs a lot. That's basically anything from social distancing, stay at home, even the mask wearing, anything that doesn't involve a pharmaceutical intervention that was designed to reduce the spread of the virus. So they said, oh, we need this. Then they introduced it, you probably remember, you were there. By mid-2020, that wave that they said would have occurred without the NPIs hadn't occurred. So they said, oh, it worked. The NPIs are working. So then they said, oh, well, maybe we can reduce it a little bit, let people have a breathing space. But then we had a new variant, a new wave, and they said, oh, we better bring back in the NPIs until we have a vaccine. But fortunately, just around the corner, January 2021, we had 4 COVID-19 vaccines, all that were supposed, according to the manufacturers, were safe and effective. So if you recall, and Pfizer in particular, 95% effective at reducing symptomatic COVID. They didn't test transmission, but you can see that's why they were saying, oh, if we can get past the herd immunity threshold with this safe and effective vaccine, we can end the whole thing. Unfortunately, by the end of 2021, they had gotten past the predicted herd immunity thresholds. Most people were vaccinated, but they were getting sick just the same as unvaccinated. A new term, breakthrough cases. Then they said, well, maybe the vaccines might reduce the severity of disease. Or they also said, oh, maybe the vaccine wanes over time, especially with the new variant. So they said, let's keep the program going. And then they said, everyone who's already gotten vaccinated, take booster doses. And so that continued for a couple of years until finally, 5th of May 2023, WHO said, look, COVID-19 is here to stay, but the global health emergency is over. So that's what we colloquially call the pandemic. So the actual disease. Now, COVID-19 is a real disease. Probably many of you have caught it. Hands up if you've caught it at some point. I caught it early on, March 2020, before the lockdowns and all of that. And then I caught it again 2 years later. It was milder the second time. But it is real. It's serious. As according to official statistics, up to now, there had been a total up to now of 704 million confirmed cases and 7 million deaths with COVID. Now, we don't know what deaths from COVID is, that's a separate issue, but just taking that, dividing 7 million divided by 704, that gives you a case fatality rate of 1%. So this was serious, a serious thing. Let's look at the US population. You can see here, that's the age profile, the breakdown for the US. This is a breakdown of the cases. And so you can see all ages caught COVID. It affected all ages. But that's just getting COVID. Now, COVID itself, as you know, there's a whole range of symptoms. Everything from hospitalization and death at one extreme down to so mild that you don't even know you have it. So having a COVID-19 case doesn't really say it. If everybody that caught COVID, it was just asymptomatic, there would have been no panic about it. So what we're concerned about is severe COVID and in particular deaths. So let's look at deaths, and you can see this was not affecting the population uniformly in terms of severity. The deaths increased with age. and so you could actually get that case fatality rate. If you divide that's spread among it. So if you are under the age of 30, it was not a killer. But if you are above the age of, say, 75, there was a significant risk. So that's the case fatality rate. But one of the things, particularly in the beginning, first year, it was impossible to get tested unless you were really, really sick, or else you were a hospital worker. So a lot of people that were mild cases, mild infections, went undiagnosed. So, but that's really what we want to know. What's the infection fatality rate? Plus, depending on things, at various stages, some governments were listing, if somebody had a car crash, they died in a car crash, but they had a positive COVID-19 test, it would be listed as a death with COVID. So that's not to say that there weren't people dying, but it's like death with COVID just meant that when they died, they had a positive COVID test. So it is difficult for working out the actual infection fatality rate. Professor John Ioannidis in Stanford, he's done a lot of work on this. He did this early on in 2021. He went to try to estimate the total infections, and he estimated 90 to 95% of the infections in the first year went undiagnosed. So that meant that the case fatality rate, which at the time was 2%, was actually, the infection fatality rate was only like 0.15%. But as we saw before, there's an age profile. So how does the infection fatality rate? You can see if you were under the age of 20, the chances of being a death with COVID, and we don't know about deaths from COVID, death with COVID, 3 in a million. If you were over 60 to 69, 1 in 200, and that increased with the age thing. So this is not uniform. There's strong differences between the population. Hospitalization, though, deaths is obviously the most severe outcome, but hospitalization is severe. Two of my colleagues, Colleen and Paul, they were given access to all of the case data in Ireland, all of the COVID-19 cases to November 2020, so it was nearly 50,000. And they had the details on if they had any other medical conditions, their age, their gender, whether they, where they lived. And so what they found was, now, if you looked at the people that were, the cases that led to a hospitalization, which was 8%, bear in mind this was 2020, the actual hospitalization rate decreased when we identified more cases, but in the early testing they were prioritizing the hospitalized, sicker people. But of the 8%, it wasn't the same as the population. The average age was 21 years older than the average cases. They had 4 times the chronic heart disease, 29% of hospitalized had chronic heart disease. You had chronic respiratory disease. The severe obesity, that's a BMI greater than 40, that was 7 times the population average. And so then we said, what about ICU? If you needed ICU, you had, it was much more, like 46% had chronic heart disease. The incidence of severe obesity was 31 times the average. So the people that required hospitalization and ICU was not taken uniformly from the population. They had other conditions, and obesity in particular, severe obesity, was a major factor. Mortality also had comorbidities. 46% had chronic heart disease. But look at this age. The average age of somebody that died of those 47,000 cases was 80.3. That's close to the average life expectancy in Ireland at the time. So it is disproportionately affecting the older people and also those that had chronic disease as well. So the one symptom that later on people said, well, okay, even if you're not at risk with hospitalization, you could get long COVID. Now, I know a few people who had long COVID, a few friends, and it is really hard. But they point out long COVID was still around before. It used to be called, if it was fatigue, it was called post-viral fatigue. But more generally, post-viral sequelae. There's different terms, but that's the basic thing. Sequelae, a sequel to your disease. And so, despite that, it is more common with COVID. Say influenza, 1.4 times the incidence for influenza. And post-viral fatigue, nearly twice the rate for flu. Cognitive symptoms, which includes brain fog, that's higher as well than flu. So it is more severe, but it did exist before, post-viral fatigue. And I will point out that obesity does seem to be a contributing factor as well. And the reason so that's the actual disease, it is serious. I mentioned obesity a couple of times, and the reason it was striking how the severity was related with increase of obesity. So if we define it in terms of the body mass index, BMI, if you're above 25, overweight, above 30, obese, above 40, extremely obese or severe obesity. And the reason, this is it, because during the pandemic, we can't make ourselves younger, and if we knew how to overcome chronic disease, we'd have been doing that anyway. But there has been a growing obesity problem. At the moment, many countries, the majority of the population is technically overweight, has a BMI greater than 25, and an increasing percentage are becoming obese. So in the US, it's over 35% obese, and then increases with severe obesity. So we had public health programs, massive population-wide. Could we not have done something to try and encourage, obviously, the individual, overcoming obesity is very difficult, but population-wide, could we have at least tried to encourage it? Might have been a good idea. Well, apparently no. For instance, this is just one example. If you wanted to go to the gym during the lockdowns, you faced fines. If you were a gym owner, even if you tried to put in safety to try and do it, you faced fines and even jail, threatened with prison sentences, you know. So now we get on to the thing. Did those NPIs actually work? So I'll tell you, there's a lot of studies you can find that say they did work. They say definitively they were excellent, they were brilliant. Millions of lives were saved by these NPIs. But when you look at them, those studies that are saying they're working, they're typically one type. One is counterfactual scenarios. That's where they will take that model, the SEER model prediction, and they said, this is what would have happened without the NPIs. This is what happened, so the NPIs worked. Okay, Popper would have called that non-falsifiable. But the other ones, what they would do is they would say, they assumed that if you had a reduction in cases, the wave was decreasing. That must be due to whatever NPIs were in place at the time. So they assumed the NPIs were working, and then they said, if we assume the NPIs are working, then the NPIs are working. Okay, that's modern science. Another thing is that they only, all of the studies I've seen finding they worked, only looked at one wave. Most of them were on the first wave, a few on the second wave. So two of my colleagues, again, Coileen and Paul, they were one of the ones that said, well, let's look at the data. So they had Ireland, they had that case data. They looked at the non-pharmaceutical interventions that were implemented at the various states, and they color-coded them. Red is the worst. And then they looked at the cases. What they found is the cases for both waves, whatever way you looked at them, they had already peaked before the major interventions had come into place. So, you know, so we then, later on, we published a preprint. We went and got, that was Ireland, we went and got 30 Northern Hemisphere countries. We looked at the total stringency of the severity. Now, so Just think about this yourself. I get into the, if these measures were working, you would expect that as you increase the strictness of the measures, you would get a reduction in the cases, right? That's what you'd expect if they're working. And then it's only when you reduce the NPIs the cases would rise. So you'd expect them to be anti-correlated. The cases that should be anti-correlated to the severity. We got the opposite. What's happening was, when cases were rising, government said, we got to do something. So they would introduce all of these measures. And then only when the cases were falling, said, oh, let's give a reward. We'll reduce the measures. So it wasn't that the NPIs were controlling the virus. The virus was controlling the NPIs. And what we also said is, we said, well, wait a second. Other coronaviruses behave seasonally. The 10 to 15% of what we call the common cold are coronaviruses. So we said, maybe they behave seasonally. There's a seasonal component. We found a huge seasonality component. It peaked in the cold and flu season, what you call cold and flu season. So we were saying the NPIs didn't work, but the seasonality seemed to be a big factor. Now, we did that study. The vaccine programs were still rolling out, so we couldn't see their effect. Also, we were looking at 30 countries, so maybe we'd lost a signal in the noise of adding all together all 30. Maybe it's better to look at a closer one. We were just using, for seasonality, we just use a cosine wave. You know, very crude, not biological, it's just, but it gave good results, which is disturbing in itself, you know. But we said, let's get with something a bit better, you know. So we published this earlier this year. We looked at used the incidence of weekly incidence of the other coronaviruses for 10 years before the pandemic as a proxy for what you would expect the seasonal contribution to be. And then we compared that, so just looking at Northern Europe, 6 countries, we said compare that with the NPIs and the vaccines. Again, for the NPIs, if anything, we couldn't find any statistically significant effect, but if anything, you were finding that the tail was wagging the dog. And the vaccines, we looked at deaths, cases, hospitalizations, also positivity rate. We couldn't find any influence of the vaccination rates on the pandemic in terms of any of these. I'm showing you here one where we got maybe a slight thing. You could look at, you can see, this is the, I don't know, can you see, the green line is the percentage vaccination. This is for Ireland, this is for the UK. The brown line is the various waves. So this is for deaths, and you could say, oh, the deaths were less after the vaccination programme for Ireland and UK. So, well, they worked, did they? Well then, how come for Finland and Norway we got the opposite result? And then how come for Sweden and Denmark it didn't make any difference? And the other thing is, look at these waves. They had no indication for vaccination. Now, we go into detailed statistical analysis. That's just the overview. We couldn't find any influence for hospitalization, deaths, or cases. But seasonality, huge influence. It looks like we get a major peak during cold and flu season, and in the summer you get a minimum in terms of severity of pandemic. And so we went ahead with these NPIs. But the thing is, what we looked, are the NPIs having negative? We were told this is to public health. We're protecting the health of the public. But up until 2020, public health specialists would tell you, public health is more than just one virus, right? So all of the policies, the public health policies, they were all sidelined in favor of this one issue of one virus. So we have, this is a detailed, I could do a whole talk on each one of these points. I don't think Jeremy would like that. Yeah, yeah, but But this is a paper we published last year, a review. I encourage you to read it. These are the heading titles of the unintended consequences for each of these sectors. Public health is more than one virus. The public health harms from these NPIs, we will be still counting the damage years from now. You saw our results empirically. We weren't finding that the vaccines were helping. But we all heard that WHO tells us that they are safe and effective. So what exactly are they effective at? So let's go back to December 2020, when everyone was told, remember, we have these safe and effective vaccines, and Pfizer was the best. 95% effective at reducing symptoms. So how did they do that? They'd had 43,000 people and they divided them into placebo and vaccine. That's impressive. That's an impressive randomized control trial. And they said 96% of the cases, confirmed cases during the 2 to 3 month trial, were in the placebo group. So 95% effective. They also said the incidence of serious adverse events was low and similar in the vaccine and placebo. Similar. We'll come back to that later. But let's just look at this 95%. How many cases? 170. So that was the basis. So it's not just Pfizer, Moderna, AstraZeneca. These are the number of participants in the vaccine, the control. This is the number of cases that were done, and this is the effectiveness. This is the absolute risk reduction. So if you said, like, you had 170 cases identified in a 2 to 3 month trial, that says that the risk, according to these results, was actually very low. But it's not, as we'll talk about later. But think about this. Essentially, each of these vaccine programs was rolled out on the basis of less than 200 cases. As of June 24th, 13.6 billion doses of COVID-19 vaccines have been administered. 70% of the world has received at least one dose. That's 5.6 billion. It seemed very low, 170. I was shocked at that. What happened? Why are we bothering with this? But it's like, well, that's why I was a bit surprised when I found out the FDA report on Pfizer's vaccine actually said, oh, well, there was 3,400 cases of suspected but unconfirmed COVID-19. So suspected but unconfirmed. They hadn't confirmed it. And then what was another thing is that it was roughly 50-50. Well, not 50, it's sort of like 40-60 in the vaccine. If all of those unconfirmed had been confirmed, and this was the result, it would have only been 19%. That wouldn't have met the WHO's or the regulators' 50% minimum. So that's a little bit, interesting. Then we look at this. Pfizer had 152 trial sites. That meant across each trial site identified an average of 1.1 cases. The whole trial, all of the staff, the whole period, all of it, they just found 1.1. So that's why I was particularly worried when I found out this whistleblower went to the BMJ and revealed a lot of issues like sloppy nature, lack of follow-up on severe adverse reactions. She had a lot of problems, but also unblinding seemed to have been a systemic problem. And so just think about that. If you are the person, you have 10, 20 suspected but unconfirmed cases coming in, and if you know that which ones are placebo and vaccine, and you are the one who decides whether to get them tested, even if you unconsciously, it may influence your results. So what happened when people did you hear? Maybe some of you heard about that. If you tried to share it on Facebook, it got fact-checked. Lead Stories said it was missing context. So the BMJ went to Facebook or to Lead Stories and said, your story, you didn't find anything wrong with our analysis. They said, oh, no, just we had some extra context. We were adding to the story. We're adding context. It's like, But he said, but you're shutting down. Facebook is using that to downrank and to penalise people. He said, well, that's nothing to do with us. You should take it up with Facebook. And then they went to the editor-in-chief of the thing. He said, oh, yeah, I see a problem. You should take it up with Facebook. They went to Pointer's International Fact-Checking Network that is in charge of all of these and Lead Stories is a signatory of. They said, take it up with Facebook. They went to Facebook. They directed them to our advice page, which basically said it's nothing to do with us. Take it up with Lead Stories. So that's this fact-checking world we're in now. But then they started these vaccine rollouts anyway, on the basis of those studies that had scientific limitations, let's say. But then you started to see studies coming out looking at the vaccine rollouts, and they said, oh, it's 90% effective just based on population, what are called observational studies. So they were very influential because they showed a high vaccine effectiveness, said, keep doing it. Problem is, every one of those papers you look at that said it was highly effective, there were confounding factors. So there's a lot of people have written on this. I recommend one of my co-authors, Norman Fenton, has a good YouTube channel and Substack. He goes through specific examples. This is a good paper as well, Fung, Jones and Dashi, that was just published, and they show specific examples. So they just give you a few of them. One of the things they said, a lot of studies defined vaccinated as 14 days after the second dose. That means 13 days after your second dose, you were unvaccinated. So what Fung et al. Did is they said, if we were to do that study to a placebo that is 0% effective with similar numbers, we'd get a 48% effective placebo. You know, I wonder how much you could sell that for. And then they looked the age profile. So the vaccine uptake was different in the age groups, but the younger age groups are more likely to be exposed because they have more contact, social interactions on average we're talking of. When you take the averages and you apply that to a placebo with the same figures, they would get a 51% effective placebo. And another one is the timing. The vaccine program's rollout started at the peak of cold and flu season, when the most severe cases were there. So you had the most severe cases in the cold and flu season, and then they started to go down as they do every year. And as they're going down, the percentage of population that's vaccinated is going up. So applying those to our placebo, we got a 67% effective placebo. So you can see why these results were not doing it. And at the end, by the end of 2021, everyone was, not everyone, but vaccinated, unvaccinated were getting COVID as well. So it wasn't 95% effective against symptomatic COVID-19. Also, it became clear they weren't stopping viral transmission. Just to pause on that for a second, those 2 points were the entire basis of the population-wide vaccine programs. But then people said, oh, it may reduce the severity of disease. And you could say, that should maybe for voluntary, if that were true. But again, it was based on those observational studies. And what happens if you correct for those confounding factors? This was published just, I think, last week. This week, we found looking at all causes, we found all-cause death risks to be even higher for those vaccinated with 1 and 2 doses compared to the unvaccinated. They found a booster might be as effective as not getting vaccinated if you could skip by them and just go to. But then they said, but that's the problem is those booster campaigns that they were looking at started in the summer. So there was that seasonality factor again. People were saying, but it might help against long COVID, which if it was true, that could be good because that affects. This study out in May, looking at all of the long COVID cases in England, they could not identify any benefit in terms of reducing long COVID from the vaccines. We talked about the disease, but I also talked about the physician and the patient, that they, Hippocrates was saying we should be working on this collaboration. So what treatments were allowed and what were not allowed? So let's just talk about masking. As we're just going through a few examples. Community masking. That became a major staple. And we were told, some people to this day are still wearing them, even voluntarily. If you did not wear a mask, if you had reasons, you had concerns, or you had issues, health issues, you were persecuted. If you were a doctor to try to provide an exemption, you often faced professional censure, to say the least. Where did they work? Well, they rolled them out as they must work. Well, there was actually, up till then, using other respiratory viruses. This is before the mask rollouts. There was 2 meta-analyses. One of them did say that it did reduce the risk relative to not wearing a mask. But this study here was also out. It is the Centre for Disease Control and Prevention. It was published there. CDC published it. They found no statistically significant difference. This study used more studies and included many of the same ones, but when they added all of the extra studies, they found that the apparent benefit disappeared. They ignored that. They went ahead. We all used them, as we know. What do we know now? This is a Cochrane reviews in 2023. So some of you probably know the Cochrane reviews are considered very highly prestigious, one of the best databases of systematic reviews. They compiled together 9 trials, more than 250,000 participants across the 9 trials. They compared, did it help wearing a medical mask or not? No statistically significant difference. What about wearing an N95, the more severe, the better ones versus a medical? No statistically significant difference. And this is another point. They said harms were rarely measured and poorly reported. Why were we not considering looking at the harms, even just societal, psychological, even the fear factor, but in kids in schools, finding problems. They couldn't see what their teacher was saying. They couldn't see what they were saying. There's a lot of things. We could do another talk on that as well, but we won't. But if you were a physician, you said, let's try to help it. Give my patients exemptions. Well, in June, Dr. Witschel in Germany, for giving medical exemptions for wearing masks, also for providing certificates to people who didn't want to get vaccinated to say, oh, you have it, so that they could continue living a normal life. She got suspended from practicing for 3 years, sentenced to jail for 2 years, 8 months, and fined the equivalent of about $50,000. So we were told, so what else? So pharmaceuticals. At the start of the pandemic, the WHO said they hadn't identified any therapies. So they basically you were told, if you got COVID-19, you were told you should recover at home, but let the hospitals know if you get really bad, and then you might come into the hospital. Get in the hospital, what happens? Standard of care, maybe supplemental oxygen. If it gets really bad, go on to mechanical ventilation. As probably quite a few of you know, for any cause, any reason, going on to mechanical ventilation has a relatively high mortality risk. So this is not like a great protocol that we had. We just really had just pray, fingers crossed. That seemed to be the main thing. Over time, some treatments were sometimes proposed, remdesivir and all, but you can see why other people were saying, can we look at repurposing widely used cheap drugs with well-known safety profiles as additional therapies. Keep those therapies, but maybe have something else that people might try. It might help. And some candidates were identified, often so safe and widely used, they were used for humans and animals. And then it's interesting, the media, instantly, whenever one of them was identified, they were vilified. And you'd often see them complaining about, oh, it's veterinary usage, you know, implying not good enough for humans. For instance, ivermectin.
One of the world's highest paid and most influential podcast hosts, Joe Rogan, just announced that he's tested positive for coronavirus. Rogan telling his 13 million Instagram followers that he was treated with several drugs, and he included ivermectin on the list, a drug used for livestock that the FDA and the CDC warn against using to treat COVID.
Turns out I got COVID. So we immediately threw the kitchen sink at it. All kinds of meds, monoclonal antibodies, ivermectin, Z-Pak, prednisone, everything.
Now, Rogan has dismissed COVID vaccines to his listeners. It's unclear, though, whether he himself was vaccinated or not. Out front now, Dr. Gregory Yu, an emergency physician in San Antonio, Texas, very familiar with ivermectin. So, Dr. Yu, obviously you're familiar with this. Most of us were not until recent days when we started to hear about this. And I understand you field daily requests from patients to be prescribed ivermectin. Rogan touting it to 13 million people, saying he was positive for COVID and trying all these drugs, including ivermectin. How dangerous is this drug, and how dangerous is it for somebody who's so influential to be pushing it?
So how dangerous? Apparently dangerous enough that in 2015 the developers of ivermectin co-won the Nobel Prize in Medicine. And it turns out ivermectin turns out to be, this is according to the Nobel Prize, these are their slides I'm just showing you here, the highly effective in both animals and humans against a variety of parasites. Other studies have shown it has antiviral properties. And the Nobel Prize Committee, they say that for Africa alone, this means more than 100,000 lives are saved each year, and the global impact and resulting benefit to mankind are immeasurable. Okay, now, some fake news apparently. So some people, some conspiracy theorists were saying that that video of Joe Rogan, it looked, did the CNN maybe add a filter to make him look sick? And apparently no. The Associated Press, they showed that they went through frame by frame. No color was altered in any way. That's good to know. So, you know.
It turns out I got COVID. So we immediately threw the kitchen sink at it. All kinds of meds, monoclonal antibodies, ivermectin, Z-Pak, prednisone, everything.
For me, whatever about the colours, I'm not disputing Associated Press, but I find it surprising that CNN just cut the clip just then, because the very next thing that Joe Rogan was saying was, and I'm fully recovered. And he's saying he'd been working out, which is kind of surprising given that he'd taken this poisonous horse dewormer. But maybe CNN didn't think that was as relevant. So does ivermectin help? Well, I mentioned the Cochrane review. So this prestigious. So this is published. And so what are the results? Does it help in hospitals? We don't know. Does it help outpatients? We don't know. Does it help as a preventative? We don't know. That's okay. Not so informative. But interestingly, if you look at their tables where they present their results, it shows that for a hospital inpatients, 40% reduction in death, 45% reduction in need for mechanical ventilation, 67% reduction in death for outpatients. They didn't test preventative. So why are they saying they don't know? Well, here's the reason why. Because they had excluded so many studies. And let's see, I'll put this back. Can I do this quick? Do you see this? The number of participants in this result was 185. So obviously the error bars were huge. Okay, so they said, oh, okay, so Because the error bars are so huge, we can't rule out the possibility that maybe it might have a negative effect. Of course, the same logic, it may be even better than they thought. But they went with, we don't know. So, but that's when you hear it might be dangerous, or it might be really, really good, because we don't know. But what if you hadn't excluded all of those studies? Well, researchers that did that and did their own meta-analyses, trying to combine the smaller studies that did have their problems, but using well-known meta-analyses techniques, they found that even it seemed to even help as a prophylaxis for preventing, that's as a preventative treatment. And Bryant et al., they found the results even if you excluded some of the more contentious ones. But then Bryant et al. In particular, do you remember the Cochrane Review authors? This is Pop et al. They wrote this kind of snarky letter saying, oh, they basically said, look, we'd gotten the same results as Bryant et al. That's easy. If we hadn't excluded all of the data, the studies, but we excluded 73% of the available studies using our predefined eligibility criteria. So that's why our work is better. So what if you were a physician that said, well, look, maybe even as a right to try, we can just see it as a supplemental because the Cochrane just says we don't know. Or you were a patient, you just said, give it a go, or try it, you can lose your job, your license. A lot of people got it, or face fines as well. So I'm going to present here a few on the safety. The 2-hour roundtable by Senator Johnson, very important. It was deleted from YouTube, but you can still find it on Rumble. And it's very hard to watch, but it is important to watch. If you, yeah. So this is the daughter, Maddie de Garay, and her mother, and Maddie and her brother were both entered into the safety and efficacy trials for Pfizer for 12 to 15-year-olds. Her brother was in the placebo, and so he was fine, but she suffered severe adverse reactions. And so her mother will say a little bit about it.
So what was said about Maddie, the next slide, if you go then to the documentation. So the New England Journal of Medicine article about the Pfizer COVID vaccine in adolescents. So first, take note that the principal investigator for Maddie's trial is the lead author for the New England Journal of Medicine article. The adverse events section has 308 words. 76 of those were dedicated to describing one single patient that had simply a temperature greater than 40 degrees. Not great to have, but that, I think this is a little more severe. There's absolutely no mention of any of Maddie's adverse reactions in that article. 0. In the EUA amendment, Maddie's adverse reaction was reduced to 5 lines that they claim was eventually diagnosed as functional abdominal pain. It's a stomach ache. By the data cutoff for the trial, on March 13th, Maddie experienced over 35 adverse events, different things happening to her, very similar to all the stories that you're hearing here. This happened during the trial. Some examples are blood in her urine, 7 times, decreased vision, loss of feeling from her waist down, dizziness, fainting, tremors, muscle weakness, and more. They're all available in the slides, all of her reactions. None of these were mentioned in either document. She went to the ER 9 times and was hospitalized 3 times for a total of 63 days, and this was by June 1st. Look at the dates of that article and around when this was approved. Maddie was in the hospital when the EUA was approved for 12 to 15-year-olds. The doctor did not even know it. So let me ask you this. functional abdominal pain, stomach ache. Does your child, when they have a stomach ache, does that put your child in a wheelchair? Does your child's stomach ache require a feeding tube? Does your child spend 64 days in hospital for their stomach ache? If they did a urine test when they have a stomach ache, would there be blood in their urine? I don't think so. I thought that Maddie would be in the best hands possible, and the rare chance she has a severe reaction, that was not the case. They did everything in their power to hide everything that happened to her. And that is why this is happening to all these other people and kids.
So Maddie there was about 1,800 in the vaccine arm of that trial. So even the most conservatives say the chances of that is 1 in 1,800. How many parents would, if they knew that there was more than 1 in 2,000 chance that their child might get that from the vaccine, how many would have given the vaccine to their children?
So what was said about Maddie?
So here's another adverse reaction. Breanne Dressen was a participant in the AstraZeneca trials for adults, and she had such severe adverse reactions on her first dose that they discontinued her. They said, we're not going to give you the second dose. Okay. It says, so they deleted her from the trial. So none of her adverse events got considered in the trial. So let's see what she has to say.
So what are the agencies doing about this? As we have heard, there's a lot of questions that need answers. The heads of the NIH, FDA, and CDC have known firsthand about my case and thousands of others. These direct reports began as early as last December. I, along with several injured physicians, continued to reach out to the FDA through emails, phone calls. We did video conferences with Peter Marks and Janet Woodcock, constant emails with Janet Woodcock and myself directly. We have literally asked and we have begged repeatedly for them to acknowledge these reactions. They declined. They know that their lack of acknowledgement has created insurmountable barrier to our ability to receive medical care from doctors who rely on these agencies for information. They know about the issues with the clinical trials, they know about the deaths, they know about the lack of follow-up on VAERS, they know about the injuries to children, they know about Maddie. I have discussed Maddie with them. They know about the mandates imposed on the injured. They know about the suicides as the results of months-long suffering. They know about the aggressive censorship. They know about the media censorship. They know about the scientific censorship. They know all of it. So,
we could say rare, very rare. What does that actually mean? Well, it turns out in drug safety, these have names. You know, this has a meaning. So you can see these terms. They refer to a particular frequency. So I'm going to show you this chart. You'll see this, and let's look at how the rates have changed over time. So June 2021, the US Advisory Committee on Immunization Practices, they admitted that, they were seeing very rare cases of myocarditis in young men. But they said, well, if the vaccines are 95% effective at preventing symptomatic COVID, well then the risks outweigh the benefits. Now we saw that claim kind of disappeared. Another study, Barda et al., they went and they even said, it's very rare. They said, but it's higher rates from catching COVID, recovering, higher rates, 11 per 100,000. Okay. Well, it turns out, do you remember I was saying they underestimated the infections in the first half of the this early part of the pandemic? Once you correct for that, there is no extra risk from myocarditis. In fact, this study here looked at the entire population for France, they found 1 in 10,000 people under 50 years developed myocarditis or pericarditis during the vaccine rollout. And 97% of those cases could be linked directly to the vaccines. And notice, we're no longer very rare. We're now at rare, okay? But despite that, WHO says clear benefits in reducing hospitalization. So clear benefits. So this is Ernest Ramirez, is the father. His 16-year-old son took the Pfizer vaccine and he died from myocarditis shortly afterwards. And so FEMA, they said that they could help out. They would give him up to $9,000 towards the funeral expenses if he agreed to say that his son had died from COVID, not from the vaccine. He declined, so he then went and he tried a GoFundMe. And he raised funds, and then GoFundMe deleted it. They said it was prohibited content. Now, so that's severe. So, but here's the thing. As time went on, researchers said, look, we can't just rely on this. Can we at least study it? So this group in Thailand, they had a high school in Thailand that was, all of the kids were going to take their second Pfizer dose. So they said, let's analyze them before and after. Let's look at everything. Echocardiograms, cardiac enzymes. We study them before and after and see, can we see any effect from the vaccines, any things? And yes, they found 29% of the kids had some form of temporary cardiovascular manifestation. That's very common. Now, okay, they were mild recovered, but that's showing that it's having an effect. 7 of the boys, that's 3.5% of the boys, developed what are called subclinical or mild myo or pericarditis. And that's common. Now, they said, oh, they all recovered within 2 weeks. But now, the thing is, subclinical myocarditis, that means that you don't know that you have it. It hasn't been identified. So what is the heart damage? What if you don't know about that heart damage? How is that going to affect the rest of your life? These are teenagers. As time progresses, this is what we're finding. There's this trickle, just getting past the peer review gatekeepers. There's this trickle over the months. You get more and more papers are published saying, finding newer adverse events that they do. But what you'll always find is, in order for the researchers to get published, they have to either say very rare, or else they have to say mild or temporary. And but let's go back. Do you remember in the trials they said similar? They said it was safety because the rates of adverse events were similar in the placebo and vaccine arm in Pfizer and Moderna. So Freeman et al. Said, let's see how similar. It turns out that 10 to 15 per 10,000 extra serious adverse events of special interest in the vaccine arm versus placebo. That's roughly 1 in 800. That is not very rare, not rare, this is uncommon. That's in that 2 to 3 month trial. This is Pfizer's data. This is before the vaccine rollout. Now, so I'd recommend check if you don't follow Rasmussen reports. They're the only ones so far that seem to be asking these hard questions. So they asked the US population. These are just surveys of the public. They're not medical experts. That's fine, but they're asking people their personal views. Do you believe you experience major, minor side effects or no side effects? 7% of Americans who were vaccinated say they had a major side effect. Only 56% said they'd no side effect. Has any member of your household died whose death you think may have been caused by side effects? 10%. Now, I will put the caveat. They asked the same question. 11% said that somebody died from COVID. So COVID is still serious, but that question is suggesting they're comparable. Do you know someone personally who died from side effects? 19%. Now, you could say maybe that's political, and certainly there is a political element, because you can see that Republicans were more likely to say yes. But even among the Democrats, 15% said that they know somebody. Now, that means 80%, 75% don't know anybody. So they think, oh, everything's rosy, everything's hunky-dory. But the people who are answering yes, they don't think it's hunky-dory. And, you know, could it be a contributing? Well, we don't know. There's lots of reasons why for excess mortality. Suicides from people that had suffered badly during the lockdowns. There could be missed treatments. But the bottom line is excess mortality has remained high in the Western world for 3 consecutive years, despite the implementation of the NPIs and the vaccines. So there should be a safety signal, at least. What if you were a physician? You were trying to express your concern. And McCluskey suspended from practicing for 1.5 years because she posted a video online expressing her concerns about the vaccines for young people. Gerard Waters, he has been suspended from practicing because he refused to give the mRNA vaccines to any of his patients. He said, you're welcome to get them somewhere else. But he said, I would not put anything in my patient's arm that I would not put in my own. That's what he said. He's now suspended from practicing. People said, oh, these weren't mandates. It was voluntary. Right, a lot of these things, a lot of these measures were voluntary. Is it voluntary when the leader of your country is calling you an extremist, a misogynist, a racist, bullying you, harassing you, threatening that you'll end up illness and death? Is that voluntary? And let me ask you this question. Just think about this paradox, because I don't have the answer. If the vaccines worked as they said they did, why was it necessary to pressurize people into taking them? Just think about it, population-wide. If they worked, why did it need to be population-wide? And if they didn't, what was the public health benefit? And if they didn't, what was the public health benefit? Having said all of that, the WHO disagrees. So, you know, maybe you should just forget what you heard. This is my last slide. On ivermectin, according to the WHO, current evidence on the use of ivermectin is inconclusive, and the vaccines are safe and effective for all individuals aged 6 months or older. And so I just want to say the reason I were able to do this at Ceres is because we get funding from donations. So we're not relying on research grants that you have to say in advance. You have to be pre-approved what you are going to find 3 years from now. So if you think that we are doing a good job and you'd like to support us, please make a donation, or even just share our work if you can. So thank you all.